want to introduce all of our fabulous panelists. I'm going to do that all at once. To begin with, we have Dr. Tanya Palermo, who is a professor of anesthesiology and pain medicine at the University of Washington with adjunct appointments in pediatrics and psychiatry. She holds the Hughes M. and Catherine Blake Endowed Professorship in Health Psychology. Dr. Palermo serves as Associate Director at the Center for Child Health, Behavior, and Development in Seattle Children's Research Institute, where she directs the Pediatric Pain and Sleep Innovations Lab. After that, we'll have Andy Schulman, who is a pediatric rheumatologist in Southern California at Children's Hospital of Orange County. He did his basic molecular biology research as an MD, PhD physician scientist and trained at Boston Children's Hospital and at University of Texas Southwestern in Dallas. He is following the path of his great clinical mentors in practicing the full breadth of pediatric rheumatology, doing molecular medicine, and leading a team as a division chief. He is a dad to two amazing daughters, 9 and 7, and enjoys maintaining an aging tennis practice. Then we have Natasha Cunningham, PhD. She is a scientist and pediatric pain psychologist and the mother of 4 kids, I just learned. She's in the family medicine department at Michigan State University. Her research focuses on the psychological assessment and treatment of youth with chronic painful health conditions. Dr. Cunningham's active research focuses on studying neural mechanisms of response to cognitive behavioral therapy, also known as CBT, for pediatric abdominal pain. And she's testing a remotely delivered CBT to target pain, depression, and fatigue in childhood onset lupus. After this panel of wonderful medical people, we will have some parents. One of our parents could not be with us tonight, but she has made a little video. Rebecca Priest Carson, who is also a nurse, is mom to Ellery, who was diagnosed with JDM at age 2. Her passions are securing a better drug than prednisone for flares and acute disease, supporting parents and advocating for pain management in JDM. She loves outdoor hiking, gardening, and being around water. Anna, I don't have nearly the kind of giant resume, but I will say that our wonderful young adult Anna has a BA in fine arts. She's an amazing painter. She's in graduate school to obtain an MSW. She's young adult living with JM since adolescence, and she hopes to work with chronically ill kids. Yes. Last and definitely not least is Michelle Best, a JM parent, coordinator of the GW Myositis Center. She also is a facilitator for NAMI Parent Support Group, and NAMI is the National Alliance of Mental Illness. Is that correct? Anyway, she also is my co-facilitator in the Cure JM Emotional Support Group, a member of the Arlington Special Education Advisory Committee, Family Assistance and Planning Team as a parent rep for Arlington. And that team, I guess, determines the level of need and approves in-home and residential mental health supports as well as foster care. So without further ado, I'm going to let Tanya take over and welcome. Oh, I wanted to add one more thing. There afterwards, you can go to our website. We have now a listing for all of the resources that people mentioned in these slides. Take it away, Tanya.
All right, can everyone see my slides? Okay, great. Well, thank you so much for the invitation to be here this evening. I hope everyone's doing well and having a good St. Patrick's Day. So as Suzanne mentioned, I'm a pediatric psychologist by training, and my career has been focused on helping children, adolescents, and young adults cope with chronic pain. And this includes across a broad spectrum of chronic conditions. And so I thought I'd approach this from a broad perspective today to really just provide an overview of chronic pain and what we call a biopsychosocial understanding of pain and how that applies to JM, and then talk specifically about pain self-management interventions that can be useful for children and adolescents, and some resources that can be easily accessed online. So Again, starting broad, what is chronic pain? For something as complex, it has a surprisingly very simple definition, which is really just pain that recurs or persists for more than 3 months. And this is sort of beyond the expected time of healing after an injury or illness. And pain's very common. 1 in 4 teens have chronic pain. So this is a condition that it impacts a great number of young people around the world. Chronic pain can be anywhere in the body. There's common locations in teens of head, abdomen, muscles, and joints, but pain can be a problem by itself or can be a problem related to an underlying disease. And today I'm merely going to focus on how cognitive and behavioral skills can help reduce chronic pain and its impact on daily life. So talk about why and how pain self-management can be used. So one of the things I recognized early on in working with children and families is just that pain has a broad impact on many aspects of daily life. For kids, it can reduce their ability to do physical activities. It can interrupt sleep, cause increase in stress and worries, anxiety and depression. It can affect school attendance and performance, affects social relationships and ability to attend social outings, and also has an impact on parents and families. It can lead to a lot of worry and stress for parents, as well as can increase financial burden in finding solutions. When we talk with children and parents directly about chronic pain, one of the things that's really striking is a worry about the future and a focus on what things are going to be like later in life. And I'll let you read some of these quotes here from parents and teens. We do a lot of qualitative work where we talk with children and parents directly to get their perspective. And again, one of the things that's important to think about the impact of pain is just not in the immediate present, but what's going to happen going forward, and really trying to find solutions to minimize the negative impact. So what does biopsychosocial mean? It's a word that you might have heard, and it really talks about the interplay between biological factors, psychological factors, and social factors. And I've thrown in health habits there because I don't know where those fit, but they're important and they influence chronic pain. So the idea really in thinking broadly about the factors that influence pain is it helps to understand why and how pain becomes complex, because all of these different types of things can influence someone's ability to cope with pain and can influence pain directly. So the biological level, things about your disease and physical health obviously impact your pain, but so does if you're going through puberty or if you're male versus female. At the psychological level, things like how you cope, whether you have anxiety or depression, can play a large role, and we'll talk more about that today. At the social level, though, also important, things about the environment, things about culture, about your socioeconomic position can also have an influence on access to resources and ultimately can impact your ability to manage pain. As mentioned, health habits are really important. Things like getting enough sleep, having physical activity in your daily life can impact pain as well. So again, very broad perspective on pain. And then you can start to understand why so many different types of treatments are considered, because there's really not ever going to be one treatment that can really address this broad range of factors. It takes multiple approaches. I also want to highlight that when we talk about chronic illness, there's a couple of other considerations, which is that, chronic pain is can be in the background, but then right in the forefront can be these things that happen repeatedly or acutely that can cause some medical trauma as well as some acute pain. So we know that many kids who have undergone chronic illness or injuries experience some traumatic stress. And this can be experienced in different ways, where you have a lot of thoughts that are negative about the trauma. You may avoid clinical situations that remind you of the trauma, and you can be what's called hyper-aroused, which is having a level of arousal in your body just from having this level of anxiety or vigilance. There's a lot of ways that people work through medical trauma. I just wanted to highlight one resource that is available here online. But again, something important just to consider in the context of coping with pain and coping with chronic disease. I also want to highlight needle procedures. Again, in the context of chronic pain, having acute pain on top of it makes it challenging to cope. Needle procedures happen frequently in kids who have chronic conditions, and we know that many children and adults have specific fears around needles. These are important to recognize because we can do something actually about needle phobia. There's very effective ways of treating it. It's not something you just have to endure and survive. You can actually learn how to cope with needle pain. So I really want to highlight that, because if you're really having that significant of struggles, really encourage identifying some ways to help. Couple of just, again, I'm going to focus on easily accessible resources today. So some accessible resources are shown here through the CDC, and then we'll talk later about SKIP, which is a great resource. It stands for Solutions for Kids in Pain, but they have a very nice section about needles. All right, so I want to highlight that anxiety and depression are incredibly common in our population, but also in people with chronic illness and in people with chronic pain. And estimates are about 1 in 3 youth with chronic pain have clinical levels of anxiety or depression. So it's a very important problem. Well, I think Dr. Cunningham's going to talk a little bit more about this topic specifically, so I'm not going to say a whole lot much more about that. But I do want to emphasize why CBT or cognitive behavioral interventions are important in thinking about how to address and manage chronic pain. So CBT interventions are what we call a type of self-management strategy, meaning that the person can do something active to learn new ways to cope with pain, new ways to think about pain. They can change behavior. So these are all things under their own control that they can manage themselves, which is why it's a self-management strategy. And it includes a broad range of strategies. So there's cognitive interventions, typically teach some type of relaxation training. There's a big focus on goal setting and activity engagement. And there's also interventions, especially for younger children, that are focused on helping parents support their teens or children in using coping skills. And we know psychological treatments have a very strong evidence base for the management of chronic pain. They've been well studied over the last 20 years for many different types of pain and within many chronic conditions. So there's really good support for incorporating them into a management plan. I want to specifically talk about a few things that are different with pain. One is that pain makes us think in ways that are a little bit unusual, and there's a style of thinking called catastrophizing that we've learned is really important. What catastrophizing means is really that we think something really negative is going to happen, and in the context of pain, what that usually means is being really feeling helpless about the ability to cope with pain, feeling like it's going to continue, never end, and so it becomes a large focus for the person. And we know that this style, unfortunately, can be related to having an experience of more pain, having greater disability related to pain, as well as more anxiety and depression. So this is a style that we sort of really want to look for, and we help people work through with CBT. So again, CBT, part of the focus is on changing some unhelpful cycles, whether it's cycles of thinking, cycles of how we react to or cope with pain, and helping people understand how this influences their physical symptoms. You can kind of see in this diagram here that, what we think about, whether it's unhelpful or helpful, can influence how we cope and the actual behaviors that we do day to day. And this can influence our actual physical symptoms, which influences our overall well-being and quality of life. And we know that having poor kind of emotional well-being or having unhelpful thoughts can make pain worse and makes coping and living with chronic pain a lot more difficult. So a big part of learning to manage pain through CBT includes learning how to manage emotional well-being. So CBT does focus on building pain coping skills as well. And again, I'm going to let Dr. Cunningham talk about that a little bit later. So one of the real problems, though, is that even though there are psychosocial treatments that are very effective for chronic pain, unfortunately, they're not very accessible in most communities. So we know that typically patients with chronic pain will receive pharmacological interventions, but only 5% actually receive any form of psychological intervention. So it's very underutilized. So why is that? So one problem is long waiting list. It's very challenging to find a psychologist in the community or at an academic medical center who has openings and who has training and experience in chronic pain. And so just finding access to these services in most communities is really difficult. And so a lot of my own career has been focused on how to take some of the treatments that we know are effective when we deliver them in clinic, but making them accessible in the home to children and families. So we've worked on both internet delivered as well as mobile applications that teach CBT skills for pain management to children. So some of the resources that I just wanted to quickly highlight is, again, if you have access to in-person or telemedicine services, this is a great way to get skills in pain management. But if you don't, there are some available online resources as well as some online groups that I wanted to just highlight today. So as mentioned, Solutions for Kids in Pain. This is based in Canada. This is a great resource, just a general resource on pain, so that covers both acute and chronic pain strategies. There's video content, there's a lot of infographics and just resource lists that are available. This is just one example of a resource list that they have for pain management apps and online resources, but there are, again, there's a focus on coping with needle pain that SCIP has, and a number of videos and resources related to that. Another resource I wanted to highlight is Comfortability. This is a program that was developed at Boston Children's Hospital by Rachel Coakley. They do workshops that are day-long intensive programs that youth and parents attend, and they do them in locations around the country who have participated in sort of training in the Comfortability program. So it's worth looking to see if there's workshops in your area, because there are a number of providers who have received this training and are offering this in the community. They also do some online chat groups and some other types of support. Another program, this is a nonprofit called Creative Healing for Youth in Pain. This is different. They're really focused on how creative healing experiences and social support can be helpful for adolescents and young adults with chronic pain. So they offer a lot of different types of programming. I know in April they have some new groups starting. They do mostly virtual groups, but again, something that can be potentially accessed. So encourage you to check them out. And then I wanted to highlight a mobile app that I've developed called Webmap Mobile. This is freely available both on iPhone as well as for Android. And the focus is really on teaching kind of core CBT skills. You can see some of the focus of the treatment modules here. And the way it works is that you kind of run through lessons, and over about a 5 to 6 week period, you get access to all of the skills and have worked through some assignments to help implement the skills. This is meant for kids who are age 10 and up. And we've implemented this in different populations and have publicly released it about 2 years ago. So we've had some good uptake and usage of this now, and have gotten a lot of good feedback from patients. We also have a book that wrote a few years ago with my colleague Emily Law called Managing Your Child's Chronic Pain that I just wanted to throw out as a resource. This is really meant to teach parents about CBT skills. So it goes through a lot of the same skills, but from the perspective of how could a parent support some of these skills with their children and adolescents. Okay, and I just wanted to throw out my contact information. I hope to answer some questions today, but if I don't get to them, please feel free to reach out to me in the future.
Thank you, Tanya. A lot of those resources I've compiled into a document, which is now available on our CureJM website under the For Families section. Look for resources for pain management. Thank you so much. Andy, go ahead and start your show.
All right, let me just get the share screen going here. Okay.
Let me know if you need help.
All right, how's that?
We don't see it yet.
Not yet. Okay, I feel like I'm getting closer. I have two monitors, which is super fancy, but I'm just not accustomed to two monitors. Let's see. Screen 2, share.
Yes. Good.
Eh? Okay.
Good.
Awesome. Thanks, guys. Thank you, Dr. Palermo. Amazing resources. I'm unfamiliar with most of them, but we should be getting the word out on those resources. So that's very exciting. Thanks so much for having me. So I thought we would go after 4 questions, and hopefully that'll address the content that will be helpful from the rheumatologist perspective. So what we'll talk about is how do we assess pain in juvenile dermatomyositis. We'll talk about pain mechanisms, and I think this will bring out some of the components that Dr. Palermo also introduced to us. We're going to talk about pain amplification and pain amplification syndrome, and what that is, what it looks like, what challenges it can present in our patients. And then we'll talk a little bit about what a treatment plan for pain amplification syndrome looks like. So how do we assess symptoms in our patients with juvenile dermatomyositis? So I imagine that this is very familiar to our families and our parents who are accustomed to their monitoring visits with your child's rheumatologist. And so, as you know, we are very tuned into learning about symptoms from our patients and families. So a detailed history is very important to understand the symptoms that our patients are experiencing. We really like to ask open-ended questions to get at what's going on with symptoms. That helps us to understand what's the timing of symptoms, what's the context, when does musculoskeletal pain happen, what type of activities seem to be correlated with the pain. And so through that process of asking open-ended questions and engaged listening, soulful listening, if you will, that really helps us to get a better sense of what's going on with symptoms, pain and other symptoms. And we really, I think, like to hear from our kids, from our patients in their own words to really get a sense of what symptoms we're trying to address. So very important to kind of have that give and take of information before we even, get into a physical exam, lay hands on the patient, or start thinking about diagnostic testing. Next step would be physical examination. And so we can get a lot of information here. So as you're accustomed from visits with your rheumatologist, what we're looking for is strength exam, looking for arthritis findings, assessing skin findings. And so, of course, the assessment of dermatomyositis is a very clinical assessment. As you know, laboratory tests and hard numeric data only give us one data piece. So it's very important to assess strength, really look at skin. So physical exam is important. And then the third and fourth thing that you see here would be more objective metrics like our laboratory tests, our inflammation markers, our muscle inflammation marker tests, and then often imaging tests are important, such as musculoskeletal MRI to assess for myositis activity, or sometimes other types of imaging like assessment of calcinosis. So that would be sort of our tools to assess dermatomyositis disease activity. What are mechanisms of pain in juvenile dermatomyositis? So disease activity, mechanical pain, pain amplification, and then a fourth category that I'll call psychic or functional pain would be different categories of pain. We'll talk about them each individually, and then in the next couple of slides, I really want to emphasize how these factors interact, right? We're not looking at each one of these components in isolation. We're interested holistically in the wellness of the person and the patient, and so clearly there can be a strong interaction between these items. And Dr. Palermo's slide that had the gears, I think, kind of brought out the same concept, that we're really looking at interconnected aspects that are having an effect on each other. So disease activity would be a primary mechanism of pain in juvenile dermatomyositis. Myositis itself, we think of as typically causing weakness or stiffness or contracture of joints, but can be painful in some settings. Arthritis, yes, pain, stiffness, limited movement. Calcinosis is kind of a unique aspect of dermatomyositis that, can pose a significant challenge in terms of pain. Mechanical aspects is very important in dermatomyositis. And so this would be chronic changes related to myositis, weakness, contracture, limitation, feeding back on normal biomechanics, causing abnormal movement or compensatory changes in mechanics, and that can together be a cause of pain related to function and activity. Third category would be this concept that we're going to introduce of pain amplification or amplified musculoskeletal pain. We'll talk more about that in a moment. And then what I'll call psychic or functional pain, I think would be more aspects of mental health, aspects of the experience of a chronic illness that also limit function, that could affect other areas like sleep, physical activity, exercise, nutrition, and impact on overall wellness. So my version of the gear slide is going to be this slide. And what you see here is those same four components that we just talked about: disease activity, mechanical pain, pain amplification, and psychic functional pain, that are all interrelated, and that's what I'm trying to illustrate with these arrows, that disease activity causes altered mechanics, mechanical pain. Perhaps mechanical pain can feed back and influence disease activity. Pain amplification can also feed back on mechanics, psychic and functional pain, and disease activity. So really, each of these things are interrelated. And what we're concerned about in our patients is if we're struggling in one domain or multiple domains, we're concerned that that's going to affect other areas and affect overall wellness. So to really kind of flip this on its head, I'd like to propose that we should not only be thinking about a complex of pain mechanisms that have this complex interaction, but we want to think about wellness in the same way, right? So instead of having a vicious cycle where one component is making others more challenging, how about a virtuous cycle where we're really focusing on wellness? And what we're going to do now is we're going to flip each of those categories, and the top category, instead of disease activity, is going to be working towards remission, good control of disease activity. The bottom left, instead of mechanical pain, is going to be improved strength and movement, improved biomechanics. In the bottom area, we're going to have a well-regulated neurologic sensitivity to pain. So essentially, pain amplification is well controlled. And on the right, the opposite of psychic pain is going to be good mental health and wellness. And so really, we want to work to holistic wellness by working on each one of those domains. let's talk a little bit more about what is pain amplification. So I like to use a thermostat metaphor. This is a overpriced Nest thermostat that we have in our house. We have a second one that's like a normal one, and it works just as well. But the concept of the thermostat is that it has a threshold of sensitivity. And so you see it's set for 68. And so when the house gets hotter than 68 or gets colder than 68, the air conditioning comes on, the heat comes on. So our nervous system has many thresholds of sensitivity that help to perceive the environment and help to process information. And you can almost think of the nervous system having a set point on this thermostat for pain perception. And it's a set point that's dynamic, right? At one, you can change the dial. You can go to 66, you can go to 70, you can go to 72. And so that where that set point is very dynamic, and it depends on many factors. In the normal setting, normal experiences, touch, movement, pressure, the environment, are going to be stimuli that are below the threshold, right? They're in the background noise, they don't activate the system. Say a person drops a hammer on their toe, now we've got a stimulus that's above the threshold, and appropriately that engages a pain response. The concept of pain amplification is, what if instead of living in this range, what if that threshold is too low? You know, the set point is too low, and we start to pick up things that should be background signal as a pain experience. What we learn is that people who have had a history of chronic pain tend to have problems with a sensitive thermostat. Their neurologic threshold for pain detection is too low. And so that would be the mechanism of pain amplification. This is a wordy slide. I don't want to take you through all of it, but what helps us to identify features of pain amplification would be triggers such as injury, sleep disruption, a disruption in someone's exercise and stress. Associated symptoms can be very important. This would be fatigue, exertional intolerance, headache, abdominal pain. Dysautonomia or autonomic dysfunction is something that we see very often, like dizziness with positional change. Also sleep disturbance, anxiety, depression. Learning about function, school absence, school activities is very helpful here. And then physical exam can actually give us a lot of information about this. A very sensitive finding for pain amplification would be touch with light pressure. And the medical term for that is allodynia, light touch or pressure causing pain. So those are features of pain amplification. The core therapies for pain amplification are what I think of as four main aspects. One would be movement with an emphasis on aerobic exercise. The second category is desensitization modalities, which includes massage and other modalities. Number three would be sleep, and number four would be working on mind-body connection, psychological therapy, cognitive behavioral therapy. And so this is a core therapeutic program that we will try to implement for patients who have pain amplification syndrome, who don't have an underlying rheumatology diagnosis. And it's also an important core group of therapies that we employ in our patients with a primary cause for chronic pain, such as dermatomyositis, to really work towards wellness and address issues with pain amplification. So I have a few additional literature resources. For those of you who are interested in digging into primary literature, I got a terrific tour of literature in this area from Kaveh Ardalan, who is an incredible, awesome pediatric rheumatologist, one of my favorite colleagues. He is a clinical investigator in the dermatomyositis area and in other areas. And so he gave me a few of his personal highlights in this area that was good for me to check out. And so I'd quickly highlight these three studies. One is looking at pain functional disability in the CARA registry. And the interesting takeaway here was that kids who have a primary pain disorder who are in that CARA registry had the highest pain scores of all the patients in the registry, but the lowest functional impairment. If you looked at dermatomyositis or other diseases like juvenile arthritis, Patients with those conditions actually scored at a lower level for pain indexes, but in their case, the intensity of pain correlated very strongly with their functional impairment or functional limitation. And I imagine we're going to have more studies of this type from the CARA registry and databases. The second point, second paper I'd highlight is looking at correlation between sleep disturbance and pain scores and quality of life scores in dermatomyositis, emphasizing the importance of sleep. And then the third is an effort in the adult population to gather patient-reported outcomes. And this is a qualitative type of research. And what's interesting about that is that, I would say that's probably an eye-opening paper for pediatric rheumatologists and adult rheumatologists, because I think it reveals that, perhaps the primary course and inflammation of dermatomyositis is more painful for individuals than we might realize. Excellent. Okay. Hopefully I'm close to on time. Susan.
Somebody has their, thank you, Annie. That was wonderful. And again, I don't have all of these resources, but I will get them from the slides and add them as needed. We are, we're a little over time, so I'm just going to go quickly to Natasha Cunningham. And again, put your questions in the chat box, please, because after Natasha, we will have a Q&A period. Okay, take it away, Natasha. Thanks, Andy. You have to stop sharing, Andy.
Okay, sorry, here I go.
Yeah.
Can you guys see my screen?
Do you want to put it in slide mode?
I will.
Yeah, I can see it.
Okay. Look good, everyone? So I'm Natasha Cunningham. I'm an assistant professor in the Department of Family Medicine at Michigan State University, based in Grand Rapids, Michigan, which is also the West Coast, but a different kind of West Coast. I'm also the co-chair of the mental health special interest group of CARA, and actually I have the great fortune of working with Kaveh Ardalan. We actually wrote a review paper together looking at anxiety and depressive symptom rates in children with different rheumatic conditions, including JM. Dr. Tanya Palermo is a real inspiration to me. She's a senior scientist in my area. So junior folks such as myself, just the opportunity to be able to do this with her is a real privilege, and just exciting to be with all of you guys today. So thank you for having me, and happy St. Patrick's Day. And those are my leprechauns taken earlier today. So I have a few questions that I'll be focusing on today. The first is kind of examining what is exactly the relationship between pain and anxiety. And I think it's helpful to just kind of take a step back and think just generally about our health and functioning. And emotional health is clearly a part of total health. And this really mirrors what Andy and Tanya have already shared with us. But really, our emotional functioning impacts our physical functioning and our social functioning as well. And these all kind of tie into our experience of illness as well, and can have an impact on chronic illness such as JM. And interesting, even if we think about the definition of pain, this is the definition that was recently updated by the International Association for the Study of Pain. And if you look at the words here, it's an unpleasant sensory and emotional experience. So it's not just the physical sensation of pain, but the actual, the emotional component is really part of the very definition of pain, which I think really reflects what Andy was talking about. And interestingly, it's resembling that or associated with actual or potential tissue damage. So sometimes there's an evident like injury or something that's very obviously causing the pain, joint inflammation, but sometimes the cause is not as readily identifiable. And that doesn't mean that it's not real. It's just that we don't always have precise means necessarily of diagnosing the pain. So the important component here that I think is important to think about is pain is really unique too to each person. We all have different tolerances for pain, and it includes both the physical aspects of pain, but also emotional aspects as well. And it's not necessarily directly related to tissue damage. So as far as how emotional health can relate to chronic health issues such as JM, I think just to step back and kind of mirror what Dr. Palermo was referencing, mental health problems in general are common in kids. And about 10 to 20% of all children experience worries or sadness that would be considered kind of debilitating for their functioning. And we know these issues can be even more common in children with chronic and health conditions and medical conditions like JM. So a few examples for you. Juvenile fibromyalgia, which was already mentioned. So this is a chronic pain condition really categorized by widespread musculoskeletal pain. It can also be associated with joint inflammation. It is not an autoimmune condition like in the way that JM is, but just to give you a sense, more than 75% of kids with juvenile fibromyalgia also have a history of issues such as anxiety or depressive disorders. Now, I mentioned I had done a review with Dr. Ardalan and other investigators looking at children with different types of rheumatic conditions and prevalence rates of anxiety and depression. There's a lot of variability, and but what we find is that there tends to be increased rates of anxiety and depression across these conditions. And unfortunately, there hasn't been a lot of specific research focused on JM so far, but I do agree, I think that is changing, and care investigators such as Kaveh are really leading the charge to increase the literature in this area. What we currently know is that greater than 40% of JM patients report significant levels of psychological distress. So again, this nearly, or actually truly doubles the rate seen in kids who are otherwise healthy. And what we know is that, broadly speaking, mental health concerns have only increased during the COVID-19 pandemic, particularly for children with chronic health issues. So these were all studies done prior to COVID-19. So what this means is right now, the rates of anxiety and depression in kids with JM and even kids in the absence of chronic health conditions are exacerbated. So things can really feel like a roller coaster, particularly for kids with JM and their families and other people who are dealing with chronic health conditions, when also dealing with other emotional or mental health related issues as well, life stressors, and just like day-to-day stressors as well. So to tell you a little bit more about anxiety, so I actually started my career as a childhood anxiety disorder researcher. And so I'm very intimately familiar with assessing and treating anxiety disorders in kids. And in my work in the last 10 to 15 years has really been focused on the intersection of anxiety and pain. But I thought it'd be helpful to first explain what exactly do we mean when we say an anxiety disorder. So there's a lot of different words kids and families might use, but basically examples of those can include worries, anxieties, fears. And what makes it different from we all worry about things, and worrying and anxiety can be adaptive. It can get us out of dangerous situations. But for some kids and adults, the worries can become bothersome and start to interfere with day-to-day functioning. And that's really a signal that would be more akin to an anxiety disorder. There's several types of anxiety disorders. Generalized anxiety, those are your kind of garden variety worriers. So, the kids, particularly, for example, the news on the war in Ukraine, the kids who really kind of resonate to things like that, it sticks in their minds. They might lose sleep at night over it, really think a lot about it. So world events, they might worry about kind of their performance and, doing things perfectly. They might worry about little things. Those are kids who might be at risk for, if it's getting in the way of their functioning, they might be at risk for having generalized anxiety. Pain can be a component of generalized anxiety too. Kids whose stomachs are in knots or they have headaches, those can be kind of physical manifestations. Then there's social anxiety. So that these are kiddos who might have, difficulties with social interactions, being assertive, maybe talking to adults or talking to peers. It can kind of look different. Some kids are really afraid of giving public speeches, others not, but there's some kind of social component. Separation anxiety is when a child has difficulty separating from their primary caregiver. And again, we have to consider the developmental context. So I have a 1-year-old, for example, she's got separation anxiety, and in her age, it's actually a normal and healthy thing. But as a child gets older, kiddos who end up in parents' bed, and I have a few of those too, if it's really hard for them to separate, if they get really emotional and it kind of sticks with them and they're bothered with it when they go to school or other events they need to do, they might be a kiddo who's dealing with separation anxiety. And then there are phobias. So Dr. Palermo talked about needle phobias. In my prior life as a child anxiety researcher, I actually worked in a phobia clinic on an NIH-funded study where we developed a brief 1-session, 3-hour-long exposure-based treatment for all different kinds of phobias. I learned a lot about how to package interventions briefly to help children with really debilitating anxiety. And so many of us don't like spiders, but if a child is maybe avoiding going outside, or if they can't go into a room for some hours or days after a spider has been there, they might be someone who may be experiencing more of a clinical phobia. And again, there really are very brief, effective interventions that can help kids with these issues. And then anxieties often co-occur. So you might often find a kiddo dealing with multiple of these at once, in addition to a chronic health condition. So again, in the last 10 to 15 years, I've really been drawn to kids who have chronic health conditions, and particularly chronic painful health conditions, who are also dealing with co-occurring mental health issues, such as co-occurring anxiety. And that intersection is where I focused a lot of my work. I mostly right now research kids who have functional abdominal pain conditions, and also children with childhood onset lupus. And really my work focused on developing tailored psychological interventions, drawing from cognitive behavioral therapy, but also addressing those comorbid mental health issues that can impact those kids. So in doing this work, some things that I found that I think are generally kind of interest to this group would be kids who have chronic pain, and again, this mirrors what others have said, but they're more likely to experience clinical levels of anxiety. So like those anxiety disorders I was referring to. In kids with chronic abdominal pain, we see more than 50% of them have it. What is really interesting is only about 30% of parents recognize anxiety in their children who had belly pain. So there's a discrepancy where, yes, there's kiddos we all know are anxious. They look anxious. They can tell you they're anxious with their words. It's obvious to their medical providers, to their family. But then there's a subset of kids where it is not obvious. Even their own parent may not be able to identify it, but they may be internally experiencing anxiety. Whether or not it's obvious, it can have an impact on health outcomes. So what this means for providers is it's really important to have standardized mental health screening tools, because these tools can capture symptoms that a child may not verbalize with their words. What we know too is that chronic pain and anxiety, when they co-occur together, these kids are likely to feel worse. And not just because they also have an anxiety disorder, but because it can actually relate to poorer health-related outcomes. So in my studies of kids with belly pain, we see higher levels of pain, higher disability due to their pain. So these are the kiddos, they have anxiety, they're more likely to be missing more school. It may be interfering more in their day-to-day functioning. So this is just a really important thing to keep in mind. I've also done some research that has showed that kids who have high levels of anxiety, they might be more likely to have GI inflammation when they have a functional abdominal pain condition, which isn't typically associated with inflammation. So there seems to be, again, some link between kind of biology and these psychological symptoms. My research has also shown that kids who have chronic pain conditions, and these are really mixed pain conditions, so it's a mix of migraine, headaches, and belly pain and musculoskeletal pain. But if they have clinical levels of anxiety, they're less likely to respond to our best pain-focused cognitive behavioral therapy. And they're at increased risk for developing other mental health issues, such as depression, substance use, and other physical health problems, such as other chronic pain conditions over time. So this is research that I did kind of in kids with kind of many different types of chronic pain conditions. And interestingly, what we found, and these are the kids who actually end up at the pain clinic. So even to get to a point of being seen by a pain subspecialist is very rare, to be able to have access to that level of specialty care. So kids who even make it through the door would really represent a small percentage of the overall number of children who struggle with chronic pain. So then, some of those were not recommended to receive CBT because of some of the reasons listed, such as access to care. Interestingly, of those who were recommended CBT, those who had anxiety were more likely to start treatment than those who didn't, which might be because they have multiple concerns, so psychological therapy sounds appealing to them. But what you see on the right-hand side is that if they have clinical levels of anxiety, they're actually less likely to respond to CBT for pain. So this is like a 0 to 10, like on the kind of very far left here, just kind of pain levels from 0 to 10. How bad is your pain? So at baseline, kids were either at a 5 or 6 out of 10. And then what you see is the kiddos who don't have clinical anxiety, those are the ones who have this black line, we call it subclinical anxiety. They experience a pretty marked reduction in their pain symptoms at the end of treatment. So they go from a 6 out of 10 to about a 2.5 out of 10. The kiddos who had anxiety disorders, they started at a 5, so they started slightly lower, but you'll see they stayed right around the same kind of range. So they're a little bit under a 5, but they barely had any movement in their pain symptoms. So I think this is pretty compelling evidence that we really need to address kind of the whole person and their co-occurring mental health issues as well when possible. CBT is the main approach I used. Dr. Palermo reviewed some of the different elements of this, and I also just have to draw attention to a really wonderful Cochrane review that she did with colleagues that kind of is a broad review of all of the psychological therapies that have been done for kids with chronic pain conditions. And she's done a few reviews looking at in-person treatments and remotely delivered interventions. And what this particular intervention showed was that there tends to be good immediate effects for psychological therapies for pain, but over time, there's less evidence of sustained effects, which might suggest that booster sessions might be useful. She also found that when looking at all the literature together, pain-focused care is less effective for addressing issues such as anxiety and depression. So this really gives evidence for maybe using an approach that addresses both of these issues when possible, a tailored approach for kiddos who are dealing with painful conditions, but also dealing with co-occurring mental health concerns. Our typical CBT for pain, it's interesting, it's highly specialized. So it's very skill focused, about 5 to 7 sessions, used to be mostly done in person. Now it's also done virtually over the past couple of years for the obvious reasons, but it's typically with a pediatric pain psychologist specialist. And oftentimes if a child has significant anxiety or mental health concerns, they're referred out for to see a community provider for those issues. Kiddo is the primary participant and parents are involved to the extent that's necessary. So for younger kids, parents would be more involved. And again, Dr. Palermo reviewed some of the skills that are often taught. Just to highlight a few other modalities that are often used. And what I would say is cognitive behavioral therapy is often like a menu of tools. And a lot of times researchers such as myself actually also integrate some of these other modalities into our treatments. So mindfulness meditation, this is something that I've also incorporated into CBT approaches I use for managing pain and comorbid mental health concerns in kids. And this is kind of a present-focused approach where you're kind of noticing your bodily sensations in a non-evaluative way and with compassion towards yourself. Another modality that's been integrated into CBT and is actually considered a newer wave of CBT is called acceptance and commitment therapy. So in cognitive behavioral therapy, we do some thought restructuring. You have a maladaptive thought, you turn it into kind of a more adaptive or positive thought. What acceptance and commitment therapy does, which is kind of interesting for kids with chronic health conditions, is there's more of a focus on accepting versus changing thoughts. And it really depends on the kid. I think certain children respond differently to different approaches, but for some children, this may yield a more powerful response. So I think multimodality treatments can potentially be effective, and then kids can get benefits from something that really resonates best with them. Biofeedback is an approach that we can use to really objectively measure the effect of different strategies like relaxation or some of these other strategies that they learn as part of a CBT or a psychotherapeutic result. So here's an image of what biofeedback might look like in a clinic. So this is a child who has migraine symptoms. So she's got kind of electrodes on her head that's connected to a computer, and it really just monitors kind of the surface muscle tension, sometimes also surface skin temperature. And what you would do is you would do a relaxation strategy and use this tool to actually see if you can see the tension kind of diminishing. So it really, in and of itself, you know, it's just really an objective way of measuring response, but we can also ask a child to report on how they responded as well. There's a lot of apps that, you know, and ways to use biofeedback. So Breathe to Relax is one that a lot of my clinician colleagues use. And it's a way that you can also kind of kind of pair some biofeedback into kind of using relaxation strategies. And Suzanne, I have a short list of some other apps that are helpful for this sort of purpose, so I can share them offline of this. This is an example of kind of breathing and mindfulness, where you're kind of noticing your breath and letting other thoughts kind of drift away and kind of returning focus to your breathing, to kind of your physical sensations. It's a little bit different than CBT, like a deep breathing, where you're working on getting like a deep breath. But really, these are all kind of different strategies that try to help increase relaxation, diminish distress and pain-related symptoms. And then I just want to briefly touch on neuroimaging techniques. So a lot of my recent research has focused on using neuroimaging to understand pain, and most recently response to cognitive behavioral therapies for pain. And again, I should mention also, I haven't really highlighted it here, but again, the approach I use for kids with lupus and with abdominal pain is I use kind of the standard pain-focused CBT, but then I've infused it with other methods, mindfulness meditation, and then some specific skills for either anxiety reduction or for kind of reducing mood symptoms or fatigue symptoms that occur very commonly for children who have lupus, and kind of developing tailored approaches based on common symptom profiles of kids with those conditions. So that's really been a focus of my work, is refining these therapies to be responsive to meet the needs of kids who have health conditions, but also co-occurring mental health concerns as well. So as far as my neuroimaging line of research, I'm just going to briefly show this. This is actually a researcher, Karen Davis, who she's a senior neuroscientist who has a long history of studying the impact of pain in the brain. And what she has found is that pain is a really complex process. And I think, you know, your kiddos know this, who are struggling with pain. People who have had chronic pain have experienced this, but neuroimaging studies really show there's multiple regions and even multiple networks that seem to be activated in response to pain. And it's a really multifaceted process, and it changes the way our brain functions. And so a lot of the work she's done with adults, I've started looking at how pain impacts the brains of kids with functional abdominal pain. There are other researchers examining that as well, in addition to looking at other chronic health conditions that are painful. And what I have found is that for children with functional abdominal pain, and some of these have only had pain for 3 months, so it's different than adults who may have experienced pain for years, but even for children who've experienced pain for a relatively shorter time, we see that their brains function differently than children who are healthy, who do not have chronic pain conditions. So what I have found in my research is that if we look at the amygdala, which is a region that's implicated in kind of emotional processing, there seems to be like hyperconnectivity between other regions that are implicated in kind of cognition, mind wandering, and also pain processing experiences as well. So I kind of summarize some of that literature here. And then I also, kids who have chronic pain, it can kind of come and go. So what we did is just for the kiddos who had chronic pain, when we were doing imaging of them to have a consistent experience, we actually induced some pain by having them drink some water. So for kiddos who have visceral pain or belly pain, similar to allodynia, where kids have increased sensitivity of kind of skin sensation, kids with visceral pain, just doing a task such as drinking water, a simple task where they're not drinking excessive amounts, but what would feel like fullness to somebody who doesn't have chronic pain can be experienced as a painful flare for them. So we imaged their brains after they drank some water, essentially, and also found increased activations in regions implicated in emotional, cognitive, and pain processing as well. So that's just a little highlight. My current research now will hopefully try to diminish some of these hyperactivations following a course of CBT for pain. So hopefully I can report back some interesting findings to you in the future. But otherwise, that's really all I have, and that's my contact information. And I'm really delighted and privileged to be here, and grateful for the opportunity to connect with you all. So thank you.
Thanks, Natasha. That was very comprehensive, all three of you. It's been lots and lots of information, and I know it's really hard to hold yourself to any 10 minutes. So I'm just going to ask one question. It's kind of a burning question, and I'm just going to put it out for anyone at this point. for anyone who wants to answer it, how do you provide accessible healthcare for neurodivergent JM patients who might be non-speaking or have situational mutism or lack the capacity for interpreting their own pain or emotions? And what if they can't communicate? How do you help them identify and communicate about their pain if you do? And lastly, how do you treat them? Who would like to take that question?
I can just briefly say I have worked with some kids with some neurodevelopmental disabilities in a clinical way. And so oftentimes I would focus on simple behavioral strategies. So for deep breathing, we might have them blow like a pinwheel or something. So just try to think of simple ways to teach some accessible skills. But really a lot of the training would also kind of be working with the parent and teaching the parent some strategies and learning from the parent different ways to help kind of optimize the needs of their kids. A lot of the CBT strategies are mostly focused for like the 8 and above crowd, but there are ways that we can tailor it for younger children and for kids who might have cognitive impairments or other types of impairments as well.
Tanya or Andy, do you have any other thoughts about how you would work with neurodivergent kids who may not be very verbal or even able to articulate their, where they might be having pain?
Yeah, it's really challenging, and it's a great question because I think this is a important population who we haven't done enough for. I would say, the assessment, there are tools that are behavioral observations that we can use that help us understand whether a nonverbal child is experiencing pain. Those can be used by providers, but as Natasha said, parents are the experts, and we really need to listen to parents and really encourage providers to listen to parents when they say there's been a change, because the parent knows that something is different, and it's really our prerogative to try to figure it out then.
The first thing that my mind goes to, Suzanne, is the younger age group. Because we have many toddler age dermatomyositis patients, right? That you can almost think of as being less verbal or less articulate because of their developmental stage. So, it probably is a similar approach in that regard, in that we need to work with the family. We need to, I think, understand triggers related to stress, anxiety. In thinking about needles from Tanya's presentation, many of our patients will receive a weekly subcutaneous methotrexate injection. And, I'm sure many of our families on the call, have a lot of experience with making that as good an experience as possible. So I think, learning about anticipatory anxiety, I try to ask some open questions about, how are the injections going? What's the experience like around that? So I think that's important in the younger spectrum of our population. I don't know that I've worked with, say, an autistic patient with dermatomyositis or something, specifically in that area. But I think, if we look more broadly at our rheumatology patient population, that is a very common scenario. And I think, sometimes getting input from the therapist that's working and the teachers that are working with that patient, with the family, can be good resources. And I think, the pain assessment is difficult. And I think for children that have sensory processing issues as a part of their developmental condition, the ability to sort of take discomfort of different types and say, okay, this is dermatomyositis pain, or this is anxiety experience, it can be very difficult to distinguish.
Thank you. Thank you. There's a lot more to be said, I think, and done for kids who are neurodivergent, and we need a lot more care in that regard. And because we are a little bit over time, I am going to skip the break part. And I'm also going to rearrange the presentation of the other panelists. So I'm going to have Anna go first because, and then the questions that are, I have other questions in the chat, which I'm going to send on to people, or if there's time at the end. I'll try to come back to them, okay? So right now, I'm going to have Anna Ramsey go ahead and do your presentation.
Hello. So my name is Anna Ramsey. Next slide, please. This first slide might look a little familiar to those of you who were at our last town hall, but my story has not changed. So I started experiencing fatigue and muscle pain when I was 13 years old, and it took a couple of years, and I was diagnosed at 15, a couple of weeks before I started 10th grade. I am now 25, and I'm still like sort of fully medicated, but I've gotten my medications down kind of to the lowest dose of everything. So I did 6 years of Rituxan, and you can see all my medications at the bottom. It's basically everything. I was also just recently diagnosed with Hashimoto's like 2 weeks ago. So I know a lot of JDM kiddos have overlapping autoimmune diseases. So Hashimoto's is a thyroid condition. So next slide. Okay, so what I am going to go into isn't all necessarily advice, but I want to point out things that have played a huge role in affecting my mental health with my journey with JDM. I think it would be helpful if you can at least understand some things your kids may be struggling with internally. None of this is meant to freak anyone out or upset anyone with any of this. I know you are all living with this every single day, but being aware is the only way to support your kiddos. Additionally, everything that I share may not be true for all JDMers. I can only speak to my experiences. So I just wanted to preface everything with that. So the biggest overlying theme, which we've been talking about all night, with this is that my pain levels are strongly correlated to the state of my mental health, and vice versa as well. When my pain levels are up, my mental health tends to go downhill and my anxiety rises. If my mental health is in the trash can, I tend to lean towards bad habits like unhealthy eating and a lack of exercise, and then my pain levels will rise. So I have learned the hard way that one of the worst things for my JDM is stress and anxiety. And being diagnosed at 15 in the middle of high school, not great. So this became really hard as I was like starting to apply for colleges. And I ended up creating a special schedule with my school that allowed me to go home 3 times a week at lunch and get the rest I needed. But skipping classes almost caused me more anxiety, but I became an incredible communicator and self-advocate as I had to work extra hard with my teachers to keep on track. And in the long run, this has really ended up being a huge life skill that I took with me to college and used with my doctors as well. And I'm now using it in grad school. And so I'm still trying to figure out how to balance stress and anxiety to keep my body in check. But I think the biggest thing I have learned that has helped me is burning out on anxiety and breaking my body won't help in the long run. So nothing is more important than taking care of my physical health, because without it, it won't matter how well I do in school if I don't have the energy to use any of what I'm learning. And this is really hard to remember, but it's just that like that pressure of school that a lot of these kids are in, obviously maybe not the younger kids, but it can really take a toll. And it's, in my opinion, not worth it if it's gonna have an effect on their bodies. So the next topic is painkillers. And this can be a little bit of a tricky topic, and I know it can be a little sensitive. My family has a history of addiction, and so my parents never let me take prescription painkillers. There were a few times when I really did need them, and they had really negative impacts on my mental health, and I chose to stick out the pain instead of feeling that way. So once again, this is my experience personally. I've talked to Suzanne, and she thought it was important for me to say this, but I live in California, where medical marijuana is legal at the age of 18 years old. My rheumatologist suggested this for me and is well aware of my use of it. It has really helped me with my pain and avoid what would have been many pain-induced breakdowns, I would say. So on Sunday nights, I take my methotrexate and I do my sub-Q treatment, and I take an edible to deal with all the side effects and the pain of the treatment. I do treatment before I go to bed, and this allows me to go get through it and get a restorative night's sleep, which without it, I honestly can't get after treatment or after taking my methotrexate. So I know that this might not be what a lot of people are comfortable with, but it is only my experience, and there is a lot of research to back it up if you are of age and if your doctor is aware. So next, I want to really drill in that just the pain is real. Like even when it is psychosomatic or if it is a PTSD reaction, what your kids are feeling presents as pain, and it doesn't feel good. So I am personally at a point where I, to some extent, live in a state of chronic pain that I've just adjusted to. And this pain is much lower than it used to be, but it is very much still there. And this means that if I am complaining about my pain, I really don't feel good. And I'm assuming that a lot of kiddos are kind of feeling the same way. So if your kid is really complaining, it shouldn't be dismissed. We really need to listen to that. So I can't remember who, but someone kind of mentioned this. There is real trauma in weekly injections and infusions. It is not necessarily the side effects. It is more the constant reminder that you are sick and your life is different from your friends. That being said, it doesn't really feel good either. I hated getting monthly infusions because of how dried up my veins were and how painful it was to get an IV. And I actually really enjoyed the actual infusion process because it felt like Grey's Anatomy. But now that I do weekly sub-Q, I have much more control over my own life and my treatment. I do not rely on the schedule of a nurse, and I do not have any recovery time. It's by no means like the worst pain that I've experienced during JDM, but it still is not always easy. And there are some weeks that it is way worse than other weeks. And those are the weeks that I overthink it, or I am stressed out, and then I get upset and it just kind of blows up. So once again, keeping that anxiety and stress down and like not overthinking these things, but it's really hard not to have that anticipatory anxiety. So this really ties in with anxiety and fear of anticipatory pain. I can easily psych myself out when doing my treatment and overthink the pain that may or may not be there even before I start. I no longer take the methotrexate shots, but I think it is the same thing for that pain and the nausea. You overthink it and expect so much your body like doesn't even stand a chance to not feel it almost. So distractions are key. Sometimes I'll have friends over while I do my sub-Q, or I'll FaceTime someone so that they can like just keep me distracted while I'm doing it. I am very lucky. I live with my boyfriend and he is super supportive and always has some distraction for me. And even like last week, it's literally a mental block. Like I couldn't push the needles in myself. And so he had to do it for me. And it's not that it hurts that bad. It's just literally like breaking your own skin, I think is really difficult for me some days. So those distractions are key, but these days just require a little extra support and love. Oh, my dog is crying. So, because we know we're going to be in more pain those days. So, as much as it makes me angry to admit it, it took me 8 years to accept that exercise really helps my pain. And sitting on the couch telling my parents that I'm resting does not. Obviously, this really depends on the stage you are in with your disease, and it took years of physical therapy for me to get there. I am not saying go run a marathon, but stretching and walking really have made a huge difference in both my mental health and my pain. So exercise, it doesn't have to be what you see on TV, but any level can help in multiple ways. So things that help me I think having something that you love to do and you can immerse yourself in is really important. For me, it's painting. It always has been since I was 5 years old. If I am in pain, I go to the studio, I will leave feeling better physically and with a whole new attitude. And this brings me to art therapy, which is why I got into a master's of social work in the first place. I'm really interested in how art therapy can help chronically ill pediatric patients because of how much I saw it help me. So taking control of my body was also huge for my mental health, but it also changed the pain. When I switched to sub-Q, it really gave me that control and the pain felt different. Even when it was like, you know, going and having a nurse try and get an IV in and doing it myself. Obviously, I'm not putting an IV in my arm, but the pain just feels much different when I'm in control of it. And I think that's had a really beneficial effect on my mental health. I am also just a big fan of therapy in general. I've been going since I was diagnosed. I highly suggest it. I know that there's stigma around it and not all families have equal access to it, which is horrible. But if you can seek it out, it is so important just to keep that stress and anxiety down and to have someone to talk to, because a lot of these kids also might not necessarily want to talk to their parents. So always remember therapy. And one last random side note, my JDM pain is way worse when I'm on my period. And my doc says this is totally normal and it causes inflammation, which makes total sense. But every month I psych myself out and I think I'm having a flare. And I don't think doctors bring this up unless you ask about it, or at least mine didn't. So I just think it's really important to let you know that you're not crazy. And that's kind of all. Oh, thank you,
Thank
Marielle.
you, Anna. Thank you. Thank you. We're going to shift, I think, Michelle, I'm going to put you up next because you're here. Do you want me to share the screen? Okay.
Please.
Mhm. Okay. Oh, hold on. I have
Oh,
to
you
stop.
need to go to the-
I know. I know.
Okay.
Let's see. Share the screen. Oh, I don't know why. Let me close this. Hold on. That'll help. Okay. Now we've got it, right?
Well, it's up, but you're on slide 4.
Yeah. Okay. How about that one?
There you go.
Okay.
So started, you're going to turn it into a slideshow.
Okay. Would you like me to? Okay.
Well, I mean,
Go.
if we can do it with the slides on the side. That's it. There we go. Okay. So this is my son, James. And I'm just going to kind of tell you about his pain story and what we have done to work our way through it, and things that I've learned through the last, oh my goodness, 14 years or so, walking James through a lot of pain. So his pain began the summer before diagnosis. We attributed his pain to jealousy of his baby brother. We actually told him that the pain in his thighs were mosquito bites. There were some mosquito bites there. He refused to walk up the stairs, and when I picked him up to carry him inside, he screamed at me because I had hurt him when I lifted him under his arms. And so we started out with a very negative pain dialogue because I did not understand that my son was in, that he was in pain. So if you go to the next slide, this picture was taken the day, this is Halloween of 2007, as you can see, it's the day before his diagnosis. The reason why James is the one who's standing, and the reason why he is standing is because he can't sit. And if he sits, he can't get up. And it was largely pain that was causing that problem. So his pain had jumped from being unwilling to walk, help me carry the toys off the beach. You know, I'm carrying a baby and James and all the beach toys in a chair, and he's refusing. Can you go? Yeah, back. So that was our start. And he was, the very next day, he was diagnosed with JDM. And shortly after that, although we had experienced pain, the screaming began, blood-curdling screaming in the car. And now you can move on to the next slide. So I'm going to skip a good bit of this because a lot of this has already been said. But the things I did want to focus on is that pain will actually mask muscle weakness. My son was handed a Toradol shortly after his diagnosis. And all of a sudden he could stand up and sit down. I'm not saying he wasn't weak, but I am saying that when there was less pain, he could actually use his body. And what this showed us, and over many years and seeing different physicians, is that providers might think that your child isn't trying very hard when they're doing some of these, like the CMOS or some of these muscle testing or the MMTs, but it might just be that it really hurts your child to do that and they don't want to hold it for very long. So that is an important factor in the pain. And the other thing that happened with my guy is that he had a lower level of, well, he had a low level of chronic pain. Eventually, you know, we got rid of the screaming, got him down to a low level of chronic pain, and he kind of stayed there for a while. And he had, you know, his ups and downs with the myositis. But all of this was complicated by a yet undiagnosed mental illness. And in the midst of all this, James ended up attending school for half days for a period of 5 years. So if you want to go to the next slide. So pain can look pretty different in children than it looks in adults. If you're trying to figure out if your kid is in pain, things to look at are they giving up preferred activities? Short-tempered, moody. I know sometimes some of this can be from steroids and there's all kinds of things that can cause this. But if you're just looking kind of for a theme, refusal to obey instructions that involve movement. Like, would you please go put this in the trash? Or you made a mess on the floor, please pick it up. And when they refuse to do that, are they agreeing to do other tasks that you've asked them to accomplish that might not hurt as much? Lying around or sleeping. This is one morning when my son did not make it to school because he was hurting so badly. My son also, he actually has a very high tolerance for pain. And one of the things that he would do is he would wrestle with his brothers, fully knowing that they're going to throw him on the floor. And he would bang into, you know, he'd bounce off of doors and he'd bounce off of walls and do things that would cause, I'm not going to say as deeply as self-harm, but he wanted to feel that pain from hitting the wall and not the constant aching and the chronicness of the pain in his legs and arms and head. So we can move on from there, but those are all things that you might see in a child who is experiencing the chronic pain. From there, we can work on creating a pain diary. Can you go to the next? So there's an app for that. Go ahead and go into your app store and see what you can find. I'm not going to recommend any specific one. A lot of people like to journal their pain diaries, but my guy was really little. So you'll see on the next screen, I did something similar to this for him. I made a little stick figure on a piece of paper. And at the time I put the little smiley faces that we've all seen, but in hindsight, and now that I'm kind of a little bit more experienced in this, I'm thinking that color-coded stickers or colored pencils might be a better choice. And this is something, at one point, it was significant enough in his life that we were doing it a couple times a day just to get a read. Does he have more pain in the morning? Does he have more pain in the afternoon? That was useful because those were questions that we were being asked. And one thing that's really important is the doctors are going to start asking you, and we've heard it mentioned a couple times, what number is your pain? So here I have created, different, you can buy stickers. You could also, especially, we see this a lot with kids with autism. I have two on the autism spectrum, not my JMer, but you often laminate things and then you can use Velcro and you can Velcro the circles onto the person, and then you might just want to take a photograph of it in order to create your own diary. But basically, I would say, so what hurts? What doesn't hurt? This hurt last time we talked. How does it feel? So in this case, you can say, my stomach is upset, or I'm having, pain from constipation, but it feels better today. So then you could put a green one there. I trained my child that once he hit an 8, if we couldn't bring it down pretty quickly, that's the time that we headed for the ER. So we actually never did go to the ER because I'm not fond of going to the ER. But so if you were to look at this, you could do the green is anywhere between like 0 and 1 or something like that. And then yellow would be 1 to 3. Your child should not have any pain. Or 2, 3, 4. Orange might be 5, 6, 7. I've always taught my son that beginning at the yellow is when we need to start to take action. Because if we don't take action while it's still yellow, it's going to rise to orange, it's going to rise to red. So to learn to take action. If you can go into the next slide. So how do you advocate for your child who's in pain? How do you get them help? And again, like I just mentioned, you record observations. You're going to share your concerns with your rheumatologist. And so I've read lots of people's complaints, but if you are given a referral to psychiatry and or pain medicine, please do not take that as a dismissal. Even if it is a dismissal, go anyway. They are your friends. You want to go there. You want to get that help. Go ahead and meet with your child's school. As I mentioned earlier, my kid ended up attending school just part-time. We've made all kinds of different types of schedules for him. Go to every specialist you can think of, if you're able to do that. Rule out what's going on and what's causing the pain. Find out if you can, what is causing the pain, because different pain requires different treatment. Muscle pain does not necessarily react to a topical like a Voltaren gel, unless you're super skinny like he was as a little guy. But joints do. Joints respond well often to a topical such as that. Muscle pain might actually respond really well to a mild muscle medicine, kind of like a Flexeril or something like that, and that would a muscle relaxer. Tylenol and Motrin are my son's friends. We worked hard to develop in the pain medicine a whole medication management for him. He does not take any of the big meds, opioids for this guy, and he avoids them with surgeries as much as he can as well. I highly recommend connecting with your pediatrician and asking them to kind of manage everything that's going on, because once you determine that pain is in multiple places and you have multiple providers, you need some place where all the information goes. And it's a lot for you to handle it on your own. So I'm a big fan of involving your pediatrician. Be open-minded to what people tell you. You might not like it, but even if you don't like it, do what they recommend. Because if you don't do what they recommend and you come back 2 or 3 months later and you haven't done what they recommend, they're going to go back and they're going to tell you to do it again. So unless you actually do it and say, okay, it didn't work, you can't really move on to find out what the next potential solution might be. And again, never get up. And one of the things I want to tell you is I was told that my son had behaviors, as I've mentioned, and I was told that my son's pain was a manipulation and that he was manipulating me. And that was never the case. He had a lot of behaviors, but and it's really easy to assume that a child with behaviors has more behaviors. And so it's really important to not let anybody tell you that your child is not in pain. All right, I'm ready for the next slide. So when mental illness and pain intersect. When this guy was 9, I took this guy out to lunch one day and this is what he gave me. He is a great kid, but his behaviors actually reached a point where they completely blew me away. I had never seen anything like it in my life. And he was eventually diagnosed with bipolar disorder. It took us a year to get him stabilized. In the midst of this, his myositis flared. So did his pain. He was literally kicking at his rheumatologist, and he regularly exhibited poor behaviors at physician visits. Like he would be fine in the car and I would take him in to go see a physician, and all of a sudden his behavior just blew up. And here I am trying to help with his pain. I'm being shut down by physicians, and it's not their fault, but they're watching this kid who comes in with, and all they're seeing are behaviors, and they're listening to mom try to figure it out. So it was very difficult to get it taken seriously. So that might have been one of the worst years of my life. It was also the best, because let me tell you, if your child does also have a mental illness, and a lot of our kids are developing severe anxiety, severe depression, or already have it, or you might have a family, where these things just happen. I had never seen anything like this, but he is a great kid now. Like, this kid is amazing because he got on the medications that he needed, and we were able to get him help. And in the midst of this, we continue to fight for help with his pain. And so we have never solved his pain problem, but his story at this point is not pain. So I want to go on to the next slide and talk to you a little bit about the spoon theory. This, I think, is important to understand. It's very true for kids, just as it is for adults. And I keep hearing about, well, my kid was out playing. They spent all day at like Great Wolf Lodge, at the water park, indoor water park, and now today they can't move. And I think now he has a flare. And no, your child has essentially, if you say spoons, let's say your child has 10 spoons, and somebody who has more pain uses spoons for more things. So for example, I get up every morning, I eat my breakfast. It really doesn't cost me a spoon to go in there and make myself a bagel and eat my breakfast and move on. Somebody who's in pain, it's going to cost them a spoon in order to go in there and put that bagel in the toaster and wait for it to cook, and then put the cream cheese on it and then go sit down. So everyone has different things that cost them. And so our kids have, essentially a set number of spoons that they can do per day. And sometimes we allow them to push it. And there's good reason for that, because our kids are kids and they need to do things that are fun. But we need to understand that the next day that there may well be a cost to that fun. So you can go ahead and switch the slide. I think it's really super important to try to source where the pain is coming from. So just look, and again, kind of back to that slide I showed you earlier, figure out where it's coming from and go to that person and try and get help. And one of the things that happened to us at one point is we were told, well, he has amplified pain syndrome by, and that is a real diagnosis and it is real pain. And there are programs that can help you with that. And we've heard great explanations of how that can happen tonight. And I just want to make sure that everybody understands how critical it is to go ahead and keep finding help for your child. In my son's case, he ended up with muscle spasms. We discovered that through the intervention of a physical therapist after we had spent, I don't know how long, trying to figure all of this out. His legs actually spasm and don't release. And they could be spasmed for a couple of days. So it was pretty intense trying to get to the bottom of his pain. In addition, we had some minor brain findings. So his headaches, we were told he didn't have headaches because they were in the wrong place. And we had an MRI run and the doctor refused to look at it. And I'm crying. And we had another MRI run. And the rheumatologist calls me and says, well, the mass in his head is unchanged. Well, it's just a cyst. It's okay. But it's exactly where he was pointing on his head. Don't stop advocating for your child. You want to go on to the next page. So if you have a child who's experiencing pain, it's really important to prepare for that. And so there are tools, and one of the, I agree, everybody who's mentioned therapy, we are so on board with that. We have learned so much from the therapy that my son has received. In addition, I recommend looking into perhaps some OT, especially for your younger kids, because everybody has things that activate them and they have things that calm them down. Some kids are very oral. Some kids can't handle loud noise. Somebody else settles down when they hear that rocking noise just going, because, if they hear that hard rock going, and that just helps them to focus and settle down. So everybody is different. And one of the things that can help your child to settle when they're in pain is just to figure out what it is that calms them instead of making them uptight. And there are things that you can do at home or, out and about to try and avoid the pain moments. That includes stretching, physical therapy, making sure that you get enough water. That can affect your pain, adequate sleep. And my son gets trigger point injections He used to get them every couple of weeks, every few weeks. He now does them every 3 months and as an outpatient procedure. I have no idea if this picture is from one of those procedures or not. He has lots of pictures that look kind of like that. But just those have made a big difference in his life and have allowed him to kind of access his life. In the moment, if you're feeling the pain, and a lot of these have already been mentioned, stretching, progressive muscle relaxation, where you kind of tighten muscles and then you kind of go from the outside in. I'd have to have my son explain it to you better. I think Natasha can explain it better than all of us, but basically you can go through that. The belly breathing, you can use a pulse oximeter if your kid likes to see things, and put a pulse oximeter on them, and they can look and try to calm their breathing in order to reduce their heart rate. And they can just watch that. And so people like to just watch that. There's procedures called guided imagery, where you can have your child close their eyes and you can walk them through being someplace else and not in their pain. Stretching in the pain, both to avoid the pain and in the pain, critical path, and the use of medicine. Again, I talked a little bit earlier, you really want to get that medicine on board before the pain becomes really, really high. I'm not saying to over medicate, because you need to make wise decisions and you need to make a plan with your physician about when you medicate and what medications you use, but you want to get in there before the pain becomes at a higher number. You want to get in there in the yellow instead of in the orange, and definitely before the red. Okay, next slide. I just want to share some of James's tools. James uses a TENS unit, which is called I'm going to read this because transcutaneous electrical nerve stimulation. Basically, it helps to get rid of the spasms in his legs, and it's a non-medication intervention that we love for him. He takes, as you can see, a cup full of meds. That's per week. That's not a day, thank goodness. He does a lot of physical therapy. He was irritated with me at this point because I was taking a picture, so he was attempting to punch me. So I'm laughing at him because he's got the thing around his neck. He gave himself a little rug burn there. James spent 4 weeks doing a program at the Kennedy Krieger Institute called the Specialized Transition Program. And we stayed in a Ronald McDonald House, and he spent all day, 5 days a week over at Kennedy Krieger learning the skills in order to be able to go back to school on time, learning how to manage pain, receiving psychotherapy. He still receives that outpatient and did before and continues to after through them. We actually travel about an hour, hour and a half to Baltimore for his therapy appointments. That's the one big blessing of COVID, is that we are actually just have to drive over the Maryland line now instead of all the way to Baltimore in order to access therapy for him. This kid has been to more doctor's appointments than I can even imagine. I don't even know how many pictures I have of him sitting on tables and sleeping while doctors are talking to him. But go to all the doctors, leave no stone unturned, figure out what's going on. And this picture took place in Philadelphia. We went there to go do a study, a research study into what some of you are familiar with, the CDASI, which is it's the cutaneous skin disease activity form. And it is super empowering for our kids to be able to participate in research. And he knows, he's done a couple of research things, and he has seen the results of his research. In his lifetime, he has seen it change from no, JDM does not cause pain to yes, it does cause pain. And he's seen a lot of the antibody research come out in his lifetime. So it's really empowering for these kids to be able to make a difference in that way. And then if you go to the next slide, to me, the most important thing for our kids is that they be able to access their life. My kid, I don't know if he's ever going to get off his meds. I have no, his JM meds. He's on, as Anna mentioned, he's also on Rituxan. He's, we're just on a long haul for him. And then he's on a lot of meds to address pain and then for his mental illness. But as you can see over here on the left, as a little guy, we had him in Taekwondo. And one of the ways we knew the kid was in pain is because x-rays actually showed that he had chipped bone in his ankles. And I still had him out on the Taekwondo floor. So if he was still complaining about pain in his legs and he was limping because of the pain from the ankle, but he's still at Taekwondo. So we eventually had to pull him because we weren't able to keep up with the pain. But again, Access Your Life. At that point, we discovered that the kid can sing. And so as a young guy, he had this opportunity to sing this solo. My kid's a bass, and that was like a soprano part over there because he was still young. It was kind of amazing to hear him sing that. And then just 2 weeks ago, I took him to Raleigh. He has continued to pursue singing, and he was in the Southern Region Honors Choir. And right now he's bald right now. He shaved his head. He normally has all this curly hair, as you've seen, and you can see he did his first shave in that middle picture because he's playing Oliver Warbucks next week in Annie. And again, one of the things I want to mention to you, as I've said in Accessing Your Life, we've recognized that James cannot do a full day. He cannot go to school at 8 in the morning and last until 5 at night. That has been too much. And so we've had to give up on some things. So he's going to do high school in 5 years. He's taking fewer classes than some of his peers. He has more time in school where he's doing an instructional studies class so he can get work done. Right now, he missed school yesterday due to pain. He went to school an hour late today due to pain. But Annie is next week, and so he's doing I don't know how many hours of Annie. So right now we are trading because my child is going to be sick for his lifetime. And because at least that's what we're thinking. He needs to have success. He requires, his mental health requires that he have these things in his life. So as a result, we are trading on, we're making a trade-off, and then the week after he goes back to academics.
Thank you, Michelle. That was incredibly comprehensive as well. And I think due to the fact that we are really at our time limit, I'm not going to play the video from Rebecca, but it will be part of the final recording, and you'll have access to that. I'll just mention that she really talks a lot about having a very young child diagnosed with JM at 18 months, and she's only about 4 now, so she's gone through a lot of pain issues with her child. It's really worth listening to. It will be part of it'll be part of the whole recording. Right now, I just would like to thank everybody tremendously for staying here and for all of your presentations. I've learned a lot. I know other people have learned a lot, and I want to open it up. If there are any last questions for anybody or anything that someone just has to say, last minute thing that you can say, and go ahead and, put your little hand up icon or stick something in the chat if you need to. Oh, really? No more questions. I know it's late. I know it's late on the East Coast, particularly. Anne, okay, go for it, Anne.
I got a question, and I don't know if this is necessarily for the doctors or the parents. We're really struggling. This is amazing that I'm on here because this is my life right now. My daughter, who is 12, is experiencing very high levels of anxiety. Her pain is pretty much in control. I mean, it's every day. It's low levels, but I'm noticing that it's really taking its toll on her anxiety. And I'm having difficulty with school, going to school, making it to school. How have the parents who have been in this for say longer than I have, really dealt with school and missing school? I'm trying to keep it as normal as possible, but I also have to kind of put different glasses on because it's not a normal situation. So how do you deal with the absences and all of that stuff?
Great question. Go ahead, Michelle, quickly.
I'm going to jump on this one.
Yeah.
Okay.
My first question would be you need to have a meeting with the school to discuss either a 504 or
We have that, yes.
You have a 504.
Yes,
So
we do have a
in that-
medical 504.
Okay, so in the 504 should be accommodations that would allow her to arrive to school late. You might want to adjust her schedule so that she has a a preferred class first so that she wants to be there on time. You might also, for the classes that she's missing, make sure that she has in her 504 that she's allowed to have class notes so that she's actually not missing the content from that. And make sure that she has an accommodation so that she can have a lesser amount of homework. And they usually word that something like reduced homework load without compromising learning or something along those lines. So that she would still have, she has to learn the material and she would be tested on it, but she wouldn't have to spend as much time doing the work, especially for these
like
classes.
the busy work. Yeah, it's a lot of busy work. Yeah.
Right.
Okay. Those are the words. Cause like I say, that we've only done the 504. This is our second year. And I'm just noticing because when we were in COVID, she was at home on the couch. So it worked really well her first year. Now we're back in school and it's taking its toll. I can really tell it's taking its toll. So that verbiage is what I need to kind of change in her 504.
Yeah, I'm putting my email in the chat, and I help people with IEPs and 504s pretty regularly. That's one of the things I do locally. And then obviously, several times for families with JM. There's also been town halls that Cure JM has put forward that you might want to check out. They might answer some of those questions as well.
Okay, thank you.
Yeah. I'm going to take two more questions. One that's in the chat. If you want to initiate mental health services for a 4-year-old with possible generalized anxiety, where do you start? Do you need to find a therapist that focuses on play therapy or CBT? I don't know. Natasha, do you want to take that one, or Tanya?
I think two websites that might be helpful would be ADAA.org, that's the Anxiety Disorder Association for America, or ABCT, which is the Association for Behavioral and Cognitive Therapy. So both of these websites have provider lists, and so there are people who identify as experts in treating anxiety disorders, or and ADAA, sorry, I can, let me throw them in. I'm sorry, I just said that.
I got it. That's okay, I'll do it.
Yeah, you'd still have to search, your list, see who would take your insurance, call them and see if they treat children your age, but those could be helpful resources for kind of where to start.
Tanya, do you have a thought, or Andy?
No, I agree with Natasha. I think that you're probably not going to search by the type of therapy, but more by the age range and the diagnosis. You want someone who is an anxiety expert and who treats young children. So those are great resources that Natasha mentioned.
Art therapy and play therapy are also quite wonderful for young kids. I had my daughter in play therapy when she was quite young.
I have a quick question.
Yeah, go Tiffany.
You think your child might have pain amplification? Is there anything particular that you do besides what we talked about with cognitive behavioral therapy and just lowering their anxiety about pain? Or are there like specialized things that you would do?
Andy, do you want to take that, or Tanya?
Hi, Tiffany. I think
Dr. Schulman's my daughter's doctor.
I think early recognition, I think, is great and very important. I think too often we recognize pain amplification when it's already causing functional limitation, and where pain amplification is becoming a significant problem. I think it's like most things, I think it's easier to treat early, before the biology and the behavioral pattern of amplified pain become more established. So I think being proactive with those core therapies, aerobic exercise, I think desensitization modalities is something that would be interesting to experiment with and learn from. And I think, yes, being very attentive to the mental health piece and also thinking about sleep. But I think, the great thing about treatment for pain amplification is I view it as a wellness program. I think if any person or kid, was attentive to those things, I think it would help support wellness and healthy pain perception and pain experience. And probably it should be something that's on the radar for all, kids, not only with rheumatic disease, but maybe all chronic illnesses, to kind of be aware of pain amplification and kind of have a health maintenance plan that focuses on wellness.
Thank you.
I was just going to comment that I think in fact, resilience and wellness should be part of what we teach all kids for coping with stress and with any type of physical symptoms. So I would see that as just broadly applicable across the board. And in the special case of pain, we know it's particularly important, but I would see it as valuable for really any of our kids to learn.
Thank you. Thank you, everybody, for coming this evening. Thank you to all my presenters, Tanya, Andrew, Natasha, Michelle. Anna had to leave, and you will have an opportunity to watch the video also with Rebecca in the future. Please, if you have any questions for any of our presenters, go ahead and send them to me. I'm suzanne.edison@curejm.org. So I'm pretty easy to find. And Jim, I don't know if you wanted to say anything, but you have a moment.
Well, I would just like to join you, Suzanne, in thanking all of our presenters for your extraordinary presentations. I certainly learned a lot. I saw a comment from Dr. Schulman that he learned a lot also, and this was just as always, we're doing everything we can to better understand how we can help parents manage this disease. And hearing these presentations and hearing from patients and parents about your own challenges has been really a great experience for us. So thank you. And I'd also like to thank, as many of you know, Suzanne, I'd like to thank Suzanne for organizing this and for continuing to drive CureJM's mental health program forward. So thank you all.
Thank you. And if anyone is interested, we do have a parent support group. It's actually going to meet this Sunday evening. Text me if you, email me if you want more information. There's a lot of stuff on our website and also on Facebook pages. So thank you. I'm going to let everybody go. Appreciate you. And stay tuned. We'll be coming back with more programming for you. Okay. Thank you.
Thank you so much.
Thanks. Good night.
Hi, I'll start by introducing myself. I'm Rebecca Kirsten, married to Brian. I'm a registered nurse. I'm a big-time environmentalist, bee lover, bird lover, and recycler. But most importantly, for our time together today, I'm the mother of a JDMer and 5-year-old Ellery. We waited a long time for Ellery, so when we were finally blessed with her, she brought us more joy than we could imagine. But paired with that joy were a lot of challenges from the start. Ellery was mildly tongue-tied, so we had to have that remedied when she was 10 weeks old. She had torticollis that we began treating when she was 3 months old. We knew that babies are all different, thinking that she was generally healthy. And she was exactly what we've been waiting for. When only a couple of months in, she started having significant gastro issues, spitting up after every meal, being constantly constipated and miserable, taking extraordinarily long time to eat, waking up at night with her legs moving. We just continued to power through. Sleepless nights continued. We heard of other parents whose kids started sleeping for long periods and just assumed Ellery simply wasn't a great sleeper. When she was old enough to start communicating with us, she would point to her legs and cry or wriggle them constantly. We were told that growing pains were likely the issue. We saw orthopedics to see if there was possible hip dysplasia. We tried probiotics for constipation and gastro issues. She took chamomile tablets, over-the-counter meds, leg massages. We did baths. And again, as a parent, you feel there might be something, but that the growing pains were most likely the cause. And Ellery was doing really great in so many other ways. She was always very verbal. She's hilarious, and she had energy during the day in bursts. And Ellery had rosy cheeks from very young. The thing about rosy cheeks is that they're kind of adorable, especially when we were told that she simply had sensitive skin or a bit of eczema. We use moisturizers and creams. Ellery has always been a big talker. Verbally, she's always been strong, but she started having a consistently gravelly voice. I pushed for a barium swallow study. Perhaps that would link some of the independent issues together. We were thickening her milk and adding probiotics to every bottle to help keep her food down. When Ellery started to get red rashes and bumps on her knuckles, something seemed off again. At the time, my dad had some warts on his hand, and we were livid, thinking he had given her warts. Around this time, my husband took her to an appointment with our PCP. I told him to be sure to ask about the leg pain, the rosy cheeks, new knuckle rashes. I knew something was off and that these independent issues were something more. My mom had had 4 kids and 2 grandkids and regularly said that none were as tough as Ellery was. Something in my gut told me there was something wrong. I wanted to push for answers but couldn't make this appointment. But my husband returned from the appointment happy to report it was just growing pains and eczema. I was frustrated. He was frustrated with me. I knew something was wrong, and he wanted everything to be all right. One of the things that we've been able to reflect on since these tough days was just how hard this was all of it was on our marriage. We were both tired. We hadn't been able to get into a good sleep pattern, as Ellery still woke up regularly with incredible leg pain. She was old enough to tell us now, but was still too young to really articulate where the pain was and what kind of pain it was. She'd be inconsolable and sobbing until finally she'd calm down, after leg massages, and fall asleep again, often on the floor of her room. But we'd be so worked up that we'd struggle to sleep. It took a toll on our mental health, our marriage, and our physical well-being. Here's the video.
You having a cough? Yeah. Is it a bad one? What hurts? Your knee hurts? Can you point to what knee? Can you point to which knee hurts?
Searching all of her symptoms, I found some info on JDM. I stumbled across some very helpful Facebook message boards. I immediately requested a referral to our local juvenile rheumatologist, and it was here, after lab work, a skin biopsy, an MRI, and a brief consult, they were finally received an official diagnosis. All of our individual issues suddenly had a correlation, and although the diagnosis was incredibly hard to hear, it also brought some relief. Since the diagnosis, it's been a lot, but we had a plan. We went to the Cure JM conference in Chicago and heard similar stories to our own. We had an additional consult with Dr. Ardalan at Lurie's Children's Hospital in Chicago and were given many new questions to bring back to our PCP and rheumatologist. At this point, we were told pain wasn't a common part of the JDM diagnosis and were not offered any medications for it. Ellery started PT, and we did ultrasound on her legs at least 3 times per week, along with PT massage. She was on high-dose steroids for 2 years, leading to a significant weight gain and new sleepless nights. This time, rather than waking up in pain, she'd wake up with so much energy, she'd need to run around our house at night for a period before going back to sleep. We bought an indoor trampoline. Finally, after months since diagnosis and a small taper in steroids, we were at the rock bottom in our pain journey. She was back up at night, this time in pain again. I finally got a referral to palliative care at the local children's hospital, and we started on gabapentin for nerve pain. It did not work, but they also suggested we start an anti-inflammatory, Mobic, also called meloxicam, and it worked. They also helped us become aware of hypersensitivity due to her chronic pain. And we started working with different textures with PT and OT to try to desensitize her chronic pain, which at that point had spread to her upper extremities as well. She at times did not even want to be picked up, which was heartbreaking. She continues to take Plaquenil and Mobic, and for the first year, we needed to get these compounded at a pharmacy across the city. Our amazing Ellery learned to take pills younger than any kid should need to learn to take pills. This happened at age 3, but she was proud. Check out this video. She still gets weekly methotrexate injections since diagnosis. The battle for the weekly shots has ebbed and flowed. She's currently at a place where she'll sit and get them over with, and then immediately ask for a show or some dessert. She gets whatever she wants on shot nights. At first, we had 2 of us holding her down and one of us giving her the shot because she was so violently opposed to them. She gets more pokes than any other kid her age. We're always monitoring her labs, so she's too familiar with her lab work. After a few years, I think she knew more and kind of mentally gave up her fight, which was sort of sad to me. She gets a donut when she gets pokes, and that works well. She's also a sunscreen professional. She reminds her kindergarten teacher to reapply before lunch recess and applies stick sunscreen to her face and neck with little resistance. We adjust our summer schedules to avoid the hottest parts of the day, but still go to the lake, play at the park, and spend time at the neighbor's pool. We had an MRI this month to see how she's doing. She seems to be doing well. She runs a lot at recess, and she loves to wrestle with her dad, uncles, and Papa. She still sometimes mentions leg pains, and we're instantly brought back to a place of anxiety, but now can hopefully reassure ourselves that maybe now they are just growing pains or fatigue. We absolutely cannot miss a Mobic. She missed one before her MRI this week, and I had to carry her to our appointment through the long hospital hallways, and at 50 pounds, now that is a struggle for me too. Our mental health struggles come in every day when we catch a glimpse of pain, or catch her choking on food, or need a stool medication to go to the bathroom. It is ever present. At times it affects us as parents as much as her in regards to our mental and emotional health. Anyone who does not sleep for 3 years straight knows the profound effect that can have. It was hard to go to family gatherings and vacations. It has been a super hard journey, and one that I would hope another JM family could prevent or avoid getting so bad that the pain of a very young JM patient becomes amplified. We lived every moment to moment, for so long that anything normal wasn't an option. And thankfully, with a very simple medication, and after years of PT, and now doing exercise in the pool as her main therapy, we can live day to day or week to week even. She's in school full time, runs with her peers, plays with cousins, and is very happy-go-lucky. We are forever thankful for her and are so glad we pushed defiantly to make it known her pain was real and not just growing pains. Even hearing a crying baby makes us go back to those scary nights where no comfort could be found. Thank you for letting us share. The Carstens.